I am loud and clear and audible to all of you. And welcome everyone to this MEDEDS series on Read Harrison's with Dr. Santosh. Today we are addressing an extremely important topic, which is aphasias. Aphasias are important for two reasons. Number one, it is important because in your neurology cases, often aphasia is one of the common complaints, because most of the cases kept in the exams are stroke cases, and aphasia can be part and parcel of many of those stroke patients. Second, aphasia had been a standard template for MCQs in the NEET PG exams, and for these two reasons it becomes an important topic for us. Okay. So what we will do is we will begin with an MCQ. Let us see if we can answer that, and then we will come back to this MCQ once we have learned the core concepts from the Harrison. So here is the MCQ. Good evening everyone, good evening everyone. So in this question we have a 35-year-old who presented with, or who has been referred by the general practitioner for assessment of speech and language, and as an expert physician you have assessed patient's speech and language, and what we decipher from our assessment is that patient was giving appropriate answers to questions. When we question him about anything basic, he was able to give appropriate answers without any undue pauses or difficulty. However, when we asked him to repeat words after the examiner, like examiner says, repeat what I say, this person was having difficulty in repetition, right? That's what I understand from the question. There were issues with repetition. He was not able to repeat words. Second thing, he had difficulty in naming familiar objects. So when he was asked to name objects which he is supposed to know, he is not able to tell the names of those objects, right? So he has issues with naming. Otherwise, when questions were asked to him, he was giving appropriate answers. Now, the examiner wants to know what kind of aphasia this patient is suffering from, whether he is suffering from Broca's aphasia, Wernicke's aphasia, transcortical motor aphasia, or conduction aphasia. What do you think should be the answer here? We have asked questions to patient. For most of the questions, he has answered appropriately. But when we asked him to repeat 3 words after me, he is not able to repeat. And when I asked him to name some familiar objects, like I gave him a pen and asked him what is it, he is not able to name it. Vakar Yunis, right now we are only focusing more on the clinical aspects. The management we will come back once we have done the basic clinical coverage, because by that time most of our second crop students would have also completed part of pharmacology. So it becomes much more easier for us to understand the guidelines, why we choose a particular drug as the first line agent, why we choose a particular drug as a second line agent. Okay, so Nilanjana thinks it is option D, conduction. Manpreet also thinks it's option D, conduction. Okay, so now tell me, what makes you think this is conduction aphasia? Why not Broca's? Why not Wernicke's? So when you go to the Harrison, right, aphasia is a very large topic there, but all of that information is just information overload, and it is not required for us. What is required for us? There is a table. So as long you know this table, your preparation for aphasias is done. Your preparation of aphasias is done. And in this table, when you look closely, he is talking about 4 components of speech assessment, right? And then he will say whether based on the observations on these components, he will classify whether it is Wernicke's, Broca's, global, conduction, transcortical, anomic, pure alexia, or pure word deafness. These are all types of aphasias, right? Now, how do we get to know whether it is Wernicke's, Broca's, global, or conduction? By looking at 4 areas, 4 domains of assessment of speech and language. What are those? The first one is comprehension. I will tell you what is the meaning of comprehension. Second one, whether the person is able to repeat the words or spoken language. The third one is ability to name the objects, and fourth one is fluency, right? So what we will do now is we will understand how we assess the speech and language of a person. Assessment of speech and language. There are 4 domains of assessment of speech and language. The first one is fluency. Fluency. Okay. So there are 4 domains of speech assessment. The first and the most important one is fluency. Can anybody define what is the meaning of fluency? What do you mean when you say that, okay, this person is really fluent in this particular language? What is the meaning of that? What do you mean by fluency? What do you mean by fluency? Okay, well, let me give you an example. Okay, so let us say we are talking about Shashi Tharoor, right? And I ask you whether his speech is fluent or not. What do you say? You will say his speech is definitely very fluent, right? Okay. In his place, let us take my own example. If I start talking in Hindi, you would say that, sir, your Hindi is not fluent. What is the difference? What is the difference between my Hindi and Shashi Tharoor's English? So if you ask me to talk in Hindi, or if you ask me to talk in a language which I am not very familiar with, when I am trying to talk, I probably need to take unnecessary pauses to build my next word, right? I would be like, हाँ इसके बाद, I need to struggle to bring the next word, हाँ इसके बाद हम वो करने वाले हैं. I am taking unnecessary pauses, right? Or I am trying to communicate with minimal number of words. I am not able to frame a proper grammatical sentence. But when you look at Shashi Tharoor's speech, he is making a jump from one word to next word without any hassle, without any struggle. Seamlessly he is transiting from one word to the next word, right? So when you listen to him, it's just one smooth flow. That's what you call as fluency. Fluency refers to ability to make a transition from one word to next word without unnecessary pauses. When we talk, we do take necessary pauses, right? To, like we call it as intonation. We try to enhance our communication by raising our voices, dropping our voice, and at sometimes taking the pause, which when we write we put comma or full stop, which are pauses, which are necessary pauses. But if I take an unnecessary pause, that means my language is not fluent, right? So when we assess fluency, the fluency can be either impaired or normal. Similarly, the next domain that we assess is the comprehension. Now what is the meaning of comprehension? Aniket Tiga, that's perfectly right? Making a transition from one word to next word without unnecessary pauses. That's the basic definition of fluency. Okay, fluency. Second one is comprehension. What is the meaning of comprehension? The third area of speech assessment is naming, and the fourth area of the speech assessment is repetition. Naming and repetition are two simple tasks. You ask the patient to name a familiar object, like give him a pen, pencil, right, or a tape or a book. He should be able to name this. This is pen, this is pencil, this is book. Obviously, we have to make sure that we give them familiar objects, right? To your patient who has never seen the town itself, who has been always staying in the village, you can't give him a colposcope and say, sir, name this please. Right? Our MBBS students themselves struggle to name the instruments in the exam, so we can't give them such complex objects. Familiar objects they should be able to name. Similarly, give them 3 words which they should be able to repeat after you. Again, obviously, give them simple words. You can't say that, okay, name Australopithecus, right, Neanderthals and something else. Give them simple words like pen, paper, pencil. They should be able to repeat in the same sequence, pen, paper, pencil. Those are 2 assessments. Now comprehension, as we say, refers to understanding, whether they are able to understand the speech. See, if you ask me one question, right, if you ask me one question, when I communicate to you, it involves many dimensions in the process. The first one is I have to first understand what you have asked me, right? That is one element of me giving you a spoken answer. First I have to understand what you have asked. One, that is comprehension. Once I understand what you have asked, I have to relate that question and information from my memory, and then my brain has to decide what should be my answer. Once I have done that decision, then I have to send that signal to the vocal apparatus, which is your vocal cords, your breathing system, and the pharyngeal muscles, tongue and oral cavity and nasal muscles, so that we finally produce that word or the sentence. That is the motor output, right? Okay. Now, so comprehension is essentially a part of our speech assessment, whether patient is able to understand spoken language or not. Okay, so first let me address fluency. Fluency can either be normal, that is unaffected, or it can be impaired or affected. Impaired or affected. Now, how do I get to know whether the fluency is affected in a patient, in a question? Unaffected, just like how we normally talk, patient is able to talk words after the words without unnecessary pauses. But if the fluency is impaired, how do I get to know? The first one, a patient with impaired fluency, when they talk, obviously they are taking unnecessary pauses. So if the patient is taking undue pauses, it is pointing towards impaired fluency. Okay. Similarly, let us say you are not so fluent in a particular language, and when I ask you a question, let us say that okay, you people are not so good in English, and I ask you a question, did you have your breakfast today morning, or did you have your breakfast this morning? If your English is tight, how would you answer? Would you say, yes sir, I had my breakfast today at 8 a.m. and it was awesome idlis? Would you give me this answer, or you would simply say yes I had, or just yes, or maybe a nod? What will you do when your fluency in this particular language is poor? You would probably say yes or maybe not, right? Because your fluency in this language is weak, right? So what should I call it as? There is lack of sufficient words. So we call it as paucity of words. Paucity of words. So if any patient, when you ask them questions, if they are communicating with very minimal number of words instead of making a proper grammatical sentence, it is pointing towards impaired fluency. If they are taking pauses unnecessarily, it is pointing towards impaired fluency, right? Then third, when you are taking unnecessary pauses, you are not constructing a proper grammatical sentence, to a listener, how will it appear? It will appear as broken language, right? Tuta puta bhasha, broken speech, broken speech. So when you see these words in a question, that a particular patient is speaking with undue pauses, or there is shortage of words, or the question says that this patient has broken speech, it is all pointing towards impaired fluency. Clear? I hope now we know how to assess whether fluency is intact or not. If fluency is intact, patient will not take unnecessary pauses. He will take pauses only in a sentence where we can put a comma or a full stop. He will frame proper sentences, and he will not be stingy, right? Conjuse nahi honge words ke saath. They will flow the words like they are uber rich with words. And thus obviously the speech will not be broken. If you have a broken speech full of paucity of words and undue pauses, it means fluency is impaired. Okay. Similarly, the next area of assessment will be comprehension, whether the patient is able to understand the spoken language or not. How do I get to know whether the patient is able to understand or not? Because comprehension can also be either unaffected or impaired, right? It can be either unaffected or it can be affected, in other words impaired. How will I recognize whether the patient's comprehension is impaired or not? So first and foremost, if you ask a question to an individual, if he has not understood what you have asked, what will he answer? If the question is only not understood, right, will you get an appropriate answer to the question you asked? Probably no, right? So he will give you unrelated answers. You ask him, what did you have for breakfast? Then he would say, weather in Delhi is terrible. Question and answer not related. Why? Because he did not understand what was the question. So when comprehension is impaired, you will start getting, right, inappropriate or unrelated answers. Inappropriate or unrelated answers. So in any condition where patient is giving you inappropriate or unrelated answers, the possibility is that he may be having impaired comprehension. This has happened many times, like see, not only aphasias, normal situations also, when in your viva OSCE, examiner asks you a question and you have not really understood, you have not studied the topic and it made no sense to you. You start talking something because you can't sit there. The silence is really uncomfortable, right? So we start blabbering something which is not related to the question. So that time the examiner knows that you don't know the topic only, you have not understood the question at all. Similarly, when you have a patient whom you ask basic questions but he start giving you unrelated answers, you know that he has not understood the question. That means his comprehension is impaired. Okay. Second, when you try to give an unrelated, like you try to give or you try to address a question which you have not understood, in your attempt to give answers, you might frame new words. Many of these patients will start framing new words which you have never heard before, which are not existent in the dictionary. What do we call it as? We call that condition as neologism. Neologism, right? coining new words. Neologism refers to coining new words. These patients have tendency to coin new words. Only one practical suggestion: when you feel that okay, this patient is coining new words, look into the dictionary once, because sometimes we may not be having a good vocabulary and patient may be more patient's vocabulary may be bigger and such words may be existing, because nowadays it's all Gen Z, right? They say lol, ROFL, which are new words to me, so I might count it as neologism, but which is not, which is part of the newer generation vocabulary. So make it a point that you look into the dictionary before you label it as having neologism and impaired comprehension. Okay, then third thing that would point towards impaired comprehension is the jargon speech. Means, what is a jargon? Trying to throw complex words, trying to create a construct a sentence which is too complex for a simple man to understand. That can happen only in two circumstances. Either you have to be Shashi Tharoor to do that unnecessarily, or you have got impaired comprehension, and that is why whatever sentences you are constructing seems to be too complex for a common individual, right? So in such cases we will call it as jargon speech. So if an MCQ talks about jargon speech, it is indirectly telling you that this patient has impaired comprehension. The same thing can also be expressed as word salad. Word salad means जनरली लैंग्वेज क्या है, एक माला है जहाँ पे शब्दों को एक माला की तरह ब्यूटीफुली पिरोया जाता है, राइट? यू अरेंज वर्ड्स लाइक अ ब्यूटीफुल गार्लैंड. दैट्स द ब्यूटी ऑफ लैंग्वेजेस. बट इफ you just throw words randomly here and there without properly following the grammar, then we will call it as word salad. So when any time a question says that this patient is giving inappropriate answers or unrelated answers to questions asked, it means comprehension is impaired. Or if the question says that patient is throwing some words which are not there in the dictionary or not heard before, that is neologism, again it means impaired comprehension. If the question directly labels the patient's speech as jargon or word salad, again it means impaired comprehension. So before we go forward, right, let us go back to this question and see what is happening to this patient's fluency and what is happening to this patient's comprehension. Read through this question and tell me what is happening to this patient's fluency and comprehension. Are they affected or unaffected? Are they affected or unaffected? Patient was giving appropriate answers to questions. That means comprehension is intact, right? It is not affected. Similarly, he was giving answers without any undue pauses or difficulty. That means fluency is also not affected. It is intact. So this patient has fluency and comprehension intact, right? Okay. Now the next two domains are pretty simple. That is naming and repetition, right? In naming, we just ask them to name familiar objects, and as long as patient is not able to name familiar objects, we would say naming is impaired. Many times what happens is, you give them a pen and they will say, they will understand what is it, right? They will be able to tell you the purpose of this. They will say that, sir, this is a writing instrument, but what is the name of it? They will struggle to say that. So as long as they can't come up with the name, naming is impaired. Clear? Many times it's like you bring the patient's child in front of them, he will say mera bachcha hai, but he will not be able to tell its name, tell his or her name. That means naming is impaired. And the last one is asking them to repeat simple familiar words after the examiner. If they are not able to repeat, that means naming, that means repetition is impaired. Okay. So now tell me in this question, what is happening with naming and repetition? Are they preserved or impaired? Naming and repetition, are they preserved or impaired? So it is clearly mentioned that patient is not able to name familiar objects. At the same time, he has difficulty to repeat the words after the examiner. That means he is not able to name, naming is impaired and repetition is impaired. So every time we get an aphasia question, right, these are the 4 areas which we will assess. And then based on what all are affected, we can come out with the diagnosis, whether it is Broca's aphasia, Wernicke's aphasia, transcortical aphasia or conduction aphasia. So for that we have this table in Harrison. One way of going forward is to memorize this table, which is a bit complex. So instead what we will do is today we will convert this aphasia topic into basic mathematics. We will get back to the school level mathematics to understand aphasias. Okay. So now tell me how many areas of speech assessment we have learned today? 4. Fluency, comprehension, naming and repetition, and we know how to identify whether fluency is intact or affected, comprehension whether it is intact or affected, similarly naming whether it is intact or affected, and repetition whether it is intact or affected. Now you can have aphasias where all the 4 areas may be affected, means patient has impaired fluency, cannot understand, cannot name, cannot repeat, right. Such aphasia where all the 4 out of 4 domains of speech assessment affected, such aphasias we will call them as global aphasia. It will be called as global aphasia. You know the meaning of global, right? Global means everything affected. So all the 4 domains affected, we will call it as global aphasia. Okay. So do you think this patient has got global aphasia? No, right? Because he has intact or unaffected fluency and comprehension, only naming and repetition are affected. So obviously he does not have global aphasia. Okay. Next we have some aphasias where out of the 4 domains that we assessed, 3 may be affected, 3 out of 4 domains affected. Okay. Now what are those aphasias? Those are the most famous aphasias that all of us know. That is Broca's aphasia and Wernicke's aphasia. So I will give you 2 stories. You should tell me which story is of Broca's and which story is of Wernicke's. Okay. So the first one, we are talking about fluency, comprehension and naming and repetition. In the first one, fluency is affected, comprehension is intact, naming is gone, repetition is gone. Okay. And in the second patient, fluency is intact, comprehension is gone, okay, naming is gone and repetition is gone. In both the cases, as you see here, in both the cases 3 of the 4 domains are affected and 1 is unaffected. In the first case it is the comprehension which is unaffected, and in the second case it is the fluency which is unaffected, right? Obviously, right, correct. So the first one is the story of a patient with Broca's aphasia. That's a case of Broca's aphasia. So in Broca's aphasia, please remember the Broca's area is concerned with the motor output of the speech. Once my brain starts framing the sentence, what I should answer, right? That sentence has to be communicated to the motor area so that we send the signals to all the muscles involved in speech production. All this is overlooked by Broca's area. So whenever there is damage to Broca's area, fluency will be gone. Okay. So the first one is obviously right, that is Broca's aphasia. So what all is affected in Broca's aphasia? Fluency is affected, comprehension is intact, naming and repetition is gone. So when I go to this patient during the bedside round and ask him a question, he will clearly understand what I have asked, right? So if I go to the rounds and ask him, how are you doing today? He understands that the question is about how am I doing today. But because he cannot frame a proper sentence, with minimal words he would communicate to me saying that okay or fine or okay. So he will communicate with minimal words. If he tries to frame sentences, he will end up taking unnecessary pauses, right? He will end up with a broken speech. If I ask him to name objects, he will struggle. If I ask him to repeat words, he will struggle. And the second story is of a patient with Wernicke's aphasia. Wernicke's aphasia. So what is this patient's story? This patient's fluency is unaffected. So he can jump from one word to next word seamlessly without any problem. But he won't understand the spoken language. So whatever question I ask him, he won't understand. So the answer I get will not be appropriate to the question I asked, right? So I go and ask him, did you take morning's medications? He will say that Switzerland is better than India, or obviously India is better than Switzerland. So he might say India is better than Switzerland. My question and his answers are not related. And in the process, he may also throw in some words which I have never heard, right? So his whole speech might be nonsensical to me, because what I asked and what I got as an answer are not related, and whatever I got as an answer is filled with words which I do not understand. So the end result is what I ask him, he does not understand, what he replies, I do not understand. That is the story of Wernicke's aphasia. So if you have to remember Wernicke's aphasia, just remember two people are talking who do not know each other's language, right? A South Indian is talking to a Chinese. Both of them don't understand each other's languages, right? So no proper communication is possible because patient does not understand the examiner's questions, and whatever the patient answers is not related to the examiner's questions, and it is filled with words which examiner cannot understand. Those are all new words or neologism. That's the story of Wernicke's aphasia. Okay. Now, do you think this patient has got Broca's or Wernicke's aphasia? No, right? Broca's and Wernicke's are conditions where out of the 4 domains we assessed, 3 are affected, only 1 is preserved. In Wernicke's, fluency is intact, and in the Broca's, the comprehension is intact. Broca's can understand, cannot speak properly. Wernicke's can speak fluently but cannot understand. That's the basic difference, right? But naming and repetition had been standardly involved in all the aphasias we discussed so far. In global, all are gone, right? In global, fluency is gone, comprehension is gone, naming is gone, repetition is gone. All are gone. So naming and repetition are standard so far, right? They are involved so far in all the aphasias we studied. Okay. Next up, we have aphasias where out of the 4 domains we assessed, only 2 are affected, 2 are intact. 2 are affected and 2 are intact. Okay. So the first one is one of the very difficult to diagnose kind of aphasias until and unless you know a proper speech assessment. So I am looking at fluency, comprehension, naming and repetition, and these are the patients where fluency is intact, comprehension is intact, only naming and repetition are affected. These are kind of difficult to diagnose aphasias because they don't get recognized by the patient's family members. Because when patient's family members interact with the patients, comprehension is intact, so they understand the question being posed to them and they are able to fluently express. So they will give a fluent answer. You ask them, Dadaji kaise hain aaj? They will say, हाँ आज ठीक है बेटा, because he understood your question and his fluency is also not impaired. Only when you go to your Dadaji and say, Dadaji देखो ये क्या है, बताओ ये क्या है, then you will notice that okay, he is not able to name this object, right? Or you go to your Dadaji and say that, Dadaji मैं आपको 3 words बोलूँगा, बता दो मैं क्या बोल रहा हूँ. When he struggles to repeat, you will recognize, right? Otherwise, many of these patients who have this aphasia, they are a bit difficult to recognize for the family members. Only when they come to hospital and we do a proper speech assessment, we assess all these 4 domains, we unearth or we get to know that this patient have impaired naming and repetition, and then such aphasias we call them as having conduction aphasia. This is conduction aphasia. This is conduction aphasia. Okay. So now in this question, do you think this patient has conduction aphasia? How many domains are affected? 2, naming and repetition. Fluency is intact, comprehension is intact. So what aphasia it is? Right, it is the conduction aphasia. Conduction aphasia is one of the difficult to diagnose aphasia because fluency and comprehension, something which we easily identify whether they are normal or not, are unaffected. Only naming and repetition are affected and we call it as conduction aphasia. Okay. Now, there are 2 more aphasias where 2 out of the 4 domains can be affected. Okay, so let me write the first one. In this one, when we look at fluency, comprehension and naming and repetition, you will notice that fluency is affected, comprehension is intact, naming is affected and repetition is intact. Okay. Now, what is this patient's story? This patient cannot communicate fluently. He will communicate with reduced number of words, unnecessary pauses, right? He will struggle to construct a proper sentence. He will minimize the number of words he will communicate because his fluency is impaired. But he will understand the questions properly. He will understand the spoken language. He will have difficulty to name the objects, but repetition he will be able to do. Is it similar somewhat to any of the previous aphasias we have studied? Is it similar to any of the aphasias previously we have studied? Okay, so now compare it with the previous aphasias and tell me, is it similar to any of the ones we have studied here? So just look at the Broca's aphasia. Okay, Broca's 3 out of 4 domains affected. One that was intact was comprehension. Here in this aphasia that we are talking about, 2 out of 4 are affected, right? But many things are similar. Fluency is affected in Broca's, fluency is affected in this aphasia also. Comprehension was intact in Broca's, comprehension is intact in this aphasia also. Naming was affected in Broca's, naming is intact in this aphasia also. And what is the difference? Repetition was affected in Broca's, now repetition is back, it is not affected. That's the only difference, right? So basically Broca's and Wernicke's aphasias with unaffected repetition, we call them as transcortical aphasias. We call them as transcortical aphasias. So this is transcortical, we can call it as transcortical motor aphasia, or you can also call it as transcortical Broca's aphasia. And if I reconstruct the Wernicke's aphasia, where fluency is fine, comprehension is affected, naming is affected, and repetition would be affected, but a patient with unaffected repetition, we will call it as transcortical sensory aphasia. Transcortical sensory aphasia, which can also be called as transcortical Wernicke's aphasia, and the transcortical motor can be called as transcortical Broca's aphasia. Similarly, this Broca's aphasia can also be called as motor aphasia, or can also be called as non-fluent aphasia, because here the fluency is gone. And Wernicke's can also be called as sensory aphasia, or you can also call it as fluent aphasia, because the fluency is unaffected. So this transcortical motor can also be called as transcortical non-fluent aphasia, and the transcortical sensory can also be called as transcortical fluent aphasia. Okay. After this, we have one more aphasia to study, where only 1 out of the 4 domains will be affected. 1 out of the 4 domains will be affected. Okay. And the story is going to go somewhat like this. When you look at the fluency, comprehension, naming and repetition, in these patients fluency will be intact, comprehension will be intact, repetition will be intact, only naming will be gone. And because only naming is affected, we call this aphasia as anomic aphasia, right? Anomic aphasia. They are unable to name the familiar objects. Again, one more difficult to diagnose kind of aphasia, because only naming is impaired. You ask them a routine question, they understand, they give you a proper answer. You ask them to repeat words, they repeat it, but you ask them to name an object, they have difficulty, right? Such aphasia are called as anomic aphasia. There are few MCQ points to learn about anomic aphasia. So when you say anomic aphasia, right, there had been one MCQ that appeared multiple times in the NEET PG and INICT. What is the most common aphasia following head injury? And on the similar lines, there can be another question asking you, what is the most common aphasia in patients with metabolic encephalopathies, like when your urea is high, carbon dioxide in the blood is high, right? When you have hyponatremia, in such conditions where brain function get affected, what is the most common aphasia? Okay, how many of you think it is anomic aphasia? See, many of you are cinema fans, right? So in the movies, generally after road traffic accident, like okay, hero तेजी से bike चलाता है, then bike से heroine गिर जाती है या hero ही गिर जाता है, right? After that they cut the scene. The next scene is in the hospital, right? ICU. पट्टी बंधा हुआ है सर पे, patient अभी conscious होता है, and patient के बाजू में patient की mother या girlfriend, boyfriend, husband, wife या बेटा कोई तो खड़ा है, and he will be asking a question, पहचान कौन, पहचान मैं कौन हूँ, and patient will not be able to name who is this person, right? Do you think the movies, that scene is irrational or that is rational? See, if the most common aphasia following head injury is not anomic, then this scene is not rational, right? अगर patient को या तो पूरा global aphasia होना चाहिए या Broca's, Wernicke's या anomic, right? So the scenes most of the times in the movies depict anomic aphasia, जो पहचान नहीं पा रहा है या नाम बता नहीं पा रहा है कौन है. They are rational. Anomic aphasias are the most common aphasia following head injury. That is the most common aphasia following head injury. Similarly, it is the most common aphasia in patients with metabolic encephalopathies. And when you say metabolic encephalopathies, that means metabolic disorders affecting the brain's function. Under this, what examples come? The first one is hyponatremia. Okay. The second one is hepatic encephalopathy. Can anybody tell me why we get hepatic encephalopathy when we have liver disorder? Cinema fake nahi hota hai, right? That's what, like, most common aphasia following head injury is anomic, and that's what many movies have shown, that the patient struggles to name the familiar person. Hepatic encephalopathy, hyponatremia, right? Then uremic encephalopathy. Can anybody tell me what is the reason why brain loses its proper function when you have liver disorder? What is the chemical responsible for the brain's dysfunction if you have liver disorder? So when blood carbon dioxide levels increase, when urea level increases, why the mitochondrial dysfunction is happening? It is because of the toxicity by ammonia. Ammonia is toxic to neurons. So when liver plays an important role in conversion of ammonia to urea, because only urea can be eliminated by the kidneys. Ammonia elimination from the kidneys is negligible. So that conversion of ammonia to urea is done by liver. So if liver is not functional, we will not be able to convert ammonia to urea. So that ammonia level increases, crosses the blood-brain barrier, start affecting the functions of the neurons. Similarly, high urea level can also be toxic to brain. So in all these conditions, we can develop anomic aphasia. Okay. Now we know how to reach the diagnosis of aphasia by just looking at the 4 domains of speech assessment. If all 4 are affected, we will call it as global aphasia. If 3 out of 4 are affected, then it has to be either Broca's or Wernicke's. In Wernicke's, it is the fluency which is intact. In Broca's, it is the comprehension which is intact. If 2 out of the 4 domains are affected, it can be conduction or one of the transcortical. Conduction is where only naming and repetition are affected. That's why I said it is one of the difficult to diagnose kind of aphasia. Transcortical motor or transcortical sensory are similar to Broca's and Wernicke's respectively, only difference being unaffected repetition. And only one affected is anomic aphasia, where naming is the one which is impaired, as the name suggests. So now I will give you one question and let us see if we can answer that. A 48-year-old presented with right hemiplegia and impaired speech. On speech assessment, it was noted that patient spoke with broken sentences marred by undue pauses, but could respond appropriately to verbal commands. He was unable to name or repeat. So repetition and naming both are impaired. Occlusion of which of the following blood vessel is responsible for this aphasia? Can explain this condition. So first make up the diagnosis. What do you think, what kind of aphasia it is, based on the 4 domains of speech assessment that you have just learned, and then we will be able to answer this question, right? So what is happening to the fluency here? What is happening to the comprehension here? What is happening to naming and repetition? Okay, what about the fluency here? Okay, we have three options. The first one is a block in the superior division of middle cerebral artery. The second one is a block in the inferior division of the middle cerebral artery. The third one is block in the MCA prior to bifurcation of the MCA into superior and inferior division. And the last one is occlusion of the anterior cerebral artery. So what type of aphasia it is? Okay, let us look at the 4 domains of speech assessment. First, as you look at the question, tell me your decision about the fluency and comprehension. So it is clearly mentioned here that patient has got broken sentences, right? And he has undue pauses. So that means fluency is definitely affected. It is not intact, right? But he is able to respond appropriately to verbal commands. Means you ask him to raise the hand, until and unless he has understood what you spoke, he will not be able to raise the hand. So that means he is understanding what you are talking. So that means that the comprehension is intact, and they directly have mentioned that naming and repetition are gone. So naming is affected, and similarly repetition is affected. So we are dealing with aphasia where 3 out of the 4 domains are affected, and only 2 differential diagnoses will remain for such condition, which is Wernicke's and Broca's, right? So in Wernicke's, it is the comprehension which is affected. That's why I told you to remember Wernicke, just remember a Chinese and a South Indian speaking to each other, right? His language he won't understand, and the South Indian's language the Chinese won't understand. That will be our situation when we are facing a patient with Wernicke's aphasia. Whatever I ask, he won't understand. What he answers, I won't understand, because it is characterized by new words. Comprehension is impaired in patients with Wernicke's. In Broca's, it is the fluency which is impaired. Naming and repetition are as such standardly affected conditions, right? So then this diagnosis becomes, this is a case of Broca's aphasia. Now to be able to answer this question, we should know where is the Broca's area located and what is its blood supply, and that completes our discussion of aphasias. Once we know the anatomical locations of the 2 major areas, the Broca's and Wernicke's, and what are their major blood supply, right? So can anybody tell me which lobe the Broca's area is located? Those who are from the first year or fresh from the first year anatomy knowledge, which area the Broca's, which lobe the Broca's area is present? Okay, so this is the lateral view of the brain, right? So this is the central sulcus, right? Let me say that this is the central sulcus. Okay, and somewhere down here I have the Broca's area as part of the frontal lobe. The Broca's area is part of the frontal lobe. What is its function? Its function is to help you in motor speech output after you have understood the spoken language. And the work of understanding is done by Wernicke's area, which is present in the posterior part of the temporal lobe, right? This is my Wernicke's area. Can anybody tell me what is the logic of having Wernicke's area in the temporal lobe? Why do we have Wernicke's area in the temporal lobe? Nilanjan, right. So it is usually, for most individuals, it is the left cerebral hemisphere which will be dominant, and the speech and language is the function of the dominant cerebral hemisphere. So only the dominant lesion will be manifesting with aphasias, right? Okay. Why should I have the Wernicke's area in the temporal lobe? Okay, so those who are fresh from anatomy, can anybody tell me in which lobe we have the area for hearing? Hearing area. The area for hearing is also in the temporal lobe. So somewhere here you might have the area for hearing. So first you hear, then you first decipher the words you heard, right? Once you get that information of what words I heard, right? Did you have breakfast? These are the words I heard. So those words will be first deciphered by the hearing area and then transferred to Wernicke's area, where the Wernicke's area makes sense of those words, right? It will understand the person is asking me, did you have breakfast? So that understanding of that language is done by Wernicke's area, right? And then you have an arcuate fasciculus which will be communicating between these regions, right? You call that as arcuate fasciculus. And the main blood supply to most part of the lateral side of the brain comes from the middle cerebral artery, and this middle cerebral artery runs in this groove called as sylvian sulcus. So this is where you have the middle cerebral artery running in this groove, right? We will call it as sylvian sulcus. It is running here, which divides into a superior division and an inferior division. It divides into a superior division and inferior division, and this superior division supplies the Broca's area, and you have a motor area here just anterior to the central sulcus. This area is the motor area. That is also supplied by the superior division of the MCA. So superior division of MCA is supplying the motor area, and that is why you end up getting the contralateral hemiplegia, one-sided weakness. And this Broca's area is also supplied by the superior division. So if I have a block here, Broca's area won't get the blood supply, so I will develop Broca's aphasia, and the motor area won't develop the blood supply, so I will develop a contralateral hemiplegia. Okay, I will repeat the whole thing again. And this inferior division is the one which is supplying the Wernicke's area. So if there is a block in the inferior division of the MCA, I will develop only Wernicke's aphasia. Generally, Wernicke's aphasia is not accompanied by hemiplegia. Okay, so just to give you summary again, whenever you hear something, right, you have a auditory area in the temporal lobe which breaks down the words you heard. Okay, so whatever that fell in my ear, these were the words. So that coding of those words is done by the auditory area. It hears, it recognizes these are the words I heard. Now what is the meaning of those words and what is the meaning of that sentence, that will be assessed by the Wernicke's areas, right? That's why we say Wernicke's area is area for comprehension. Once I understand what I heard, right, I made the sense of that sentence, now I frame an answer to that question. Now whatever I need to speak, that will be communicated with the Broca's area. So Broca's area grammatically orders the words and sends that information to motor area. Motor area sends the signals down to the muscles of speech, which is your vocal cords, pharyngeal muscles, tongue, right, oral cavity muscles and nasal muscles, so that you end up producing your voice, right, you end up framing a sentence. This is how the speech apparatus works. So if I have a block in the superior division of MCA, the blood supply to Broca's area and the motor area is gone. So if I lose the functioning of the motor area, opposite side body will lose the movement. That is what we call as contralateral hemiplegia, and I will lose the fluency. So I end up getting what we call as Broca's aphasia and contralateral hemiplegia. If there is a block in the inferior division of middle cerebral artery, then blood supply to the Wernicke's area is gone, and then I will end up losing my ability to understand the speech. My fluency will be fine, right? I will be able to move my body parts, but I won't understand the speech. That is what we call as Wernicke's aphasia. And if there is a damage to this arcuate fasciculus, we end up getting the conduction aphasia. We end up getting conduction aphasia. And if the block happens in the middle cerebral artery before it bifurcates into superior and inferior division, then Wernicke's will also be gone, Broca's will also be gone, and we end up developing global aphasia. Clear? So a lesion of Broca's area causes Broca's aphasia, Wernicke's area causes Wernicke's aphasia, arcuate fasciculus lesion causes what we call as conduction aphasia, causes conduction aphasia. So now tell me, what should be the answer for this question? This patient has got Broca's aphasia, and as we understand, he also has got right hemiplegia. So where should be which blood vessel should be blocked? See, arcuate fasciculus communicates between your Broca's and Wernicke's areas, and if there is any lesion or damage to arcuate fasciculus because of a tumor or an infarction, that will result in impaired communication between the two areas, and what manifests is conduction aphasia. Patient will have fluency, patient will have comprehension, but he will have difficulty in naming and repetition. That is what we call as conduction aphasia. 2 out of 4 domains affected, and the affected domains are naming and repetition, and that is one of the difficult to diagnose aphasia, which I have been repeatedly telling. The reason being, only naming and repetition are impaired. Until and unless we ask the patient to name or repeat words, we will never get to know. Otherwise, for routine conversation, their speech is fluent, their understanding is unaffected. right. So, here it has to be the occlusion of the superior division of MCA. So, occlusion of superior division of MCA leads to Broca's aphasia, and that's why that should be our answer here. Occlusion of the inferior division leads to Wernicke's aphasia. Wernicke's aphasia, and the occlusion of the MCA prior to the bifurcation of superior and inferior division, right, that will lead to global aphasia, because that will cut the blood supply to both the Wernicke's as well as the Broca's area. Anterior cerebral artery has no major role in regulation of the speech. Clear? Anterior cerebral artery does not have a major role or major blood supply to the areas concerned with the speech. Okay. If I have a block in the anterior cerebral artery, most likely I will develop the hemiplegia predominantly affecting the lower limbs more than upper limbs, and I can have bladder dysfunction. More on that we will discuss once we start discussing the neurological localization of stroke, how to identify the site of lesion in a patient with neurological dysfunction. For now, let us restrict to aphasias. Global aphasia refers to aphasias where all the 4 areas of speech are affected, that is fluency, comprehension, naming and repetition. So, please remember, Broca's area is concerned with the fluency, motor output. Wernicke's area is concerned with the understanding of the speech. Okay. And how efficiently you can communicate between the 2 areas will decide about your naming and repetition. Okay. So, once the Broca's area is affected, we will get Broca's aphasia. Wernicke's area affected, we will get Wernicke's aphasia. But if both the areas are gone, patient cannot understand, cannot speak fluently, cannot name, cannot repeat. All the 4 domains of speech assessment will be impaired. Such patient will be called as having global aphasia. That typically happens when you block the middle cerebral artery before it bifurcates into superior and inferior divisions, right. So, that is it about aphasias, guys. Now, what I would suggest is go to the Q banks and solve MCQs on aphasias. That will help you in 2 grounds. Ground number 1, aphasia is a common complaint that you will see patients presenting with in your wards. Most of the patients with stroke, right, will have aphasia as one of the component, and examiners generally take your discussion to Wernicke's versus the Broca's, and nowadays the trend is gone beyond differentiation into Wernicke's and Broca's. They also talk about conduction aphasia, they also talk about transcortical aphasia. So, you will be able to comfortably answer those questions. Second, almost every alternate exam will have one question on the aphasias. So, you can ensure that you will get definitely those 1 marks if you solve some MCQs today, right. I will also be leaving some MCQs in the notes for you to address, and this is the simplest and easiest way to approach aphasias. Those who find this approach difficult, you also have a table in the Harrison to memorize. Whichever works for you, you can follow that, but do not ignore this topic. One MCQ is almost assured, and almost every neuro case you present in the wards, the discussion invariably goes into aphasias, because speech assessment is part of your neurological examination, and examiners will at least ask you basic questions. So, let us make ourselves comfortable in addressing that. So, for today that is it, guys. Nilanjana, okay. See, what we have assessed today was primarily the central processing of the speech. Once we go to the cranial nerves, we will also understand a few more terms like dysarthria, dysphonia. I will give you a basic concept today. So, when I speak, right, let me say you have asked me a question. I understood that what you have asked with the help of my Wernicke's area, right. My auditory area heard the words, it passed on that to the Wernicke's area. Wernicke's area helped me understand the meaning of the sentence or the question that you asked. Now, I have to give you an answer. So, from Wernicke's area, information will be going to my memory to figure out what should be my answer. And once my mind has figured out what should be my answer, my Broca's area helps me to build a sentence based on the answer that I want to give, right. And once it helps me to build a sentence, it will send that information to the motor area. And what is motor area? Motor area is concerned with the voluntary contraction of the muscles. So, it will send the signal to motor area through cranial nerves will send the signal to my vocal cords first, right. And which cranial nerve is regulating the vocal cords? Which cranial nerve, right? 10th cranial nerve, recurrent laryngeal nerve, which is part of your 10th cranial nerve. So, through that information will come to the vocal cords, right. Now, vocal cords will regulate the exhaled air that is coming out. It will vibrate so that the air column which is coming out as an exhalation is modulated, and that is how we produce the sound or the letters. But whatever letters that are produced by the vocal cords, that's not finally what I hear, because that sound is further modulated. Like see, for example, everybody's voice is different. Everybody's vocal cords are pretty similar anatomically, but voice is different, right? Himesh Reshammiya is also singer, Sonu Nigam is also singer, but when you listen to Himesh Reshammiya, you feel that the sound is mostly coming from the nose. When you listen to Sonu Nigam, it feels like the sound is mostly coming from the throat or maybe from the soul, right? What is the difference? Because once vocal cords produce the sound, we modulate that sound further by regulating or moving my muscles in the oropharynx. Then I also modulate that sound in my oral cavity. Like, you know, many words we cannot produce without touching our lips, right? Many words we can't produce, many letters we can't produce if I close my lips. When we talk, many letters require a tongue to touch the palate, right? So that's how we further modulate the sound that is generated by the vocal cords in my oropharynx, oral cavity, as well as I may or may not involve the nose depending on how I generally speak. So all this modulation, even if my vocal cords work fine, if I have difficulty in modulation of those sounds, it may not still sound normal, right? Such abnormalities is what we call as dysarthria. Dysarthria basically refers to impaired modulation of the sound produced by vocal cords. And then what is dysphonia? Dysphonia refers to impairment of the sound production by the vocal cord itself because of the localized vocal cord pathology. Aphasia refers to the problem higher up in the brain where we are not able to send the appropriate signals to the vocal cords to frame or generate words. That's what happens when we have Broca's aphasia. From the brain only I am not sending the appropriate signals to generate words. I am sending less words, vocal cord is producing less words. But if I am sending proper words, proper sentence, but my vocal cord cannot generate the sound properly, that is dysphonia. If my vocal cord generates properly, but then I cannot modulate it because I have cranial nerve palsy, right? 9th, 10th, hypoglossal nerve, those are all required for me to be able to properly produce words, properly, for it to sound properly. So if I am not able to regulate that, then it may still sound unnatural. In such cases, we call it as dysarthria. So dysphonia is vocal cord dysfunction. Dysarthria is the dysfunction of the muscles in your oropharynx, oral cavity and nose. Typically happens when you have the palsy of cranial nerve 9, 10 and the hypoglossal nerve. Clear? Okay. So that's it for today, guys. I will communicate through the Insta as well as there will be a list put up of the next classes on the PW Meded channel. Okay. So that's it for today, guys. I will be leaving 2 or 3 MCQs for you to solve in the notes, which will be available on the Meded channel soon. Okay. Thank you, guys. Have a good night and see you soon on YouTube. Bye-bye.